Hello, Neil.
Hello. Hello, Michael. All right.
Good. To remind everyone that the meeting is in public and that it will be recorded.
Yeah, that's fine. We'll do that. Are we recording it and keeping it then, or are we just recording it for the purposes of minutes and things?
It is being on YouTube, so I think there will be a recording available
For people to look at later on. Yeah. Oh, better watch our manners then. Right, just to go through the technicalities then. With this thing, you've got a chat box, haven't you? But you haven't got a hands up thing, have you? It's just a chat box.
It's just a chat box.
Oh, I've got a hands up.
Have you?
Yeah, so on the participants list at sort of bottom right, there's a row.
Yes, I found it.
Yeah.
Yeah. Where does that show then? Have I got my hand up now? I've just...
No, because I can't seem to actually see the list of participants to see what's going on.
Put your hand up then, Chris.
Yes, you have got your hand up.
So mine's up.
Oh, yes, I can see it now. Yeah. Have I got my hand up? Yes, I have.
Yeah, there we go.
Excellent. Could everybody see the hand? I'll take it down. Okay, I don't need to put my hand up, but there is a hand up option. Okay. So, right, so shall we get started? Just to be clear, who's putting up the is somebody putting up the agendas or anything, or what are we going to do with the papers? Are they coming up on the screen, or are we just looking at them on our own screens?
Are you going to go through?
It's not something I've practiced doing.
I think it's probably best if they're looked at on individual screens.
Okay. Yeah, I mean, to be perfectly honest, unless it's a PowerPoint or something, it's not always that necessary. And if we're going through it, it's not always going to be helpful, is it? So why don't we rely on people to look at their own screens then for the documents? Is that going to work out for everybody? And we'll just make a start. Okay. So again, just to reiterate what Michael said about this is our first meeting in public and it will be recorded. So obviously just bear that in mind. So do we have any, well, first of all, to go for apologies, because there's a few apologies, aren't there?
Yes, there are. There are apologies. Anne Murray, Joey Taylor, Krishna Patel is going to leave early. Chris Ford and Alison Burrett may leave early.
Yeah. And we've got, so we've got Maria, haven't we, for Anne, is that right?
Yeah.
Yeah. Right, I've got all that down. Anybody I've missed anywhere?
You've got Vicky Head for Muriel Scott as well.
Oh, hi, Vicky.
Hello.
Okay, so right, let's just make a start then. Would anybody like to declare any interests before we make a start on any particular items? And that really means anything that isn't the obvious one. Okay. Now bear with me a minute because I just need to get the papers up. Right, the next, were there any matters arising? Don't think there was anything in that. Just tell me if I'm wrong. It's quite a sort of hefty wad of paper. Otherwise, we're moving on to the action log. Which I think we do need to go through because it's not complete. So let's just go down through this from last time then. There's the first 3 actions are complete. Then we've got another action, number 4. This is a meeting to discuss communications and public engagement going forward. I've got a suspicion that that's been discussed and that's happened, doesn't it? Alison or Jane?
Hello. Yes, we're sorry. Am I stepping in over Alison?
No, go ahead, Jane.
Thank you. So we are working on that, and it's moved on quite considerably. We just need to fill in the action log. I apologise.
Yeah, I thought so. So that's completed. The next item is comments about the following to be added to the risk register, just to check if all those items are now attached to the risk register.
So the risk register is on the agenda. It's been and we're going to put new risks on there based on and working with the committees to get them on there. So it's not yet done.
Okay, so that's on the way but not complete. Okay. The next item is the committee minutes. Chief Finance review the financial risk posed by added to the MT Board Assurance Framework. And again, that's reviewing the financial risks, hasn't it? Has that been completed, or is that still something that needs to be actioned?
I'm afraid I have no updates about Nicola at this point, so that's still outstanding.
That's Stephen.
Yes.
Yeah, sorry, you're a bit quiet. Okay, so we'll have to keep that on then. And the next one is the COVID-19 incident response to recovery plan. And this is about this year, so I remember this one about the secondary care pathways, to have a discussion about the secondary care pathways outside the governing body meeting. Has that discussion taken place? Helen, are you there? Sorry, I can't remember. So we're unsure if that's taken place. We just need to hold on to that one then. Okay, item 8. And this is about responding to an email from the Director of Strategy, Planning and Population Health and the Chief Finance Officer outside of the meeting on the phase 2 of the recovery plan.
Nicola, it's Mike Thompson. We received some feedback from colleagues on the call and we incorporated that where relevant into the plans.
Lovely. And we're moving on with the recovery plan anyway, aren't we? So should we call that one complete? Yeah, exactly. And the next item, COVID-19 incident response phase 2 recovery plan, follow-up communication strategy about COVID-19 and risk. So there was a conversation between Chirag and Jane about the COVID-19 and risk. Is that completed?
Thank you.
Sorry, Jane, you go ahead.
I think it's a time and place thing again, and it has been completed. Thank you.
Yeah, moved on. Okay. Number 12, 1 BLMK CCG programme. Nikki was going to send further details about appointments to clinical roles to the governing body. And yeah, that's all completed, isn't it? I think, Nikki.
All complete.
Yeah. Then number 15, one BLMK CCG programme, re-establish members forums to various questions regarding clinical recruitment can be discussed. And we have had members forums, haven't we?
Yeah.
Established and done. So that's complete. And the next one is EPRR, joint training for executive team. Oh, that's summer 2020. Is that presumably hasn't happened yet, has it? No.
No, Nicola, we're going to do that in light of what later on in the summer.
Something to look forward to for the future. Lovely. Okay. This is, I think these might be old ones on here, aren't they? They've got different, sorry, I'm having to look really close because the writing is really small. The first one on the top is about the long-term plan update. And there is an update on that from May. Where are we going with that item?
Nicola, it's Mike. I think that's now been brought into the recovery planning process because the intended updates to the long-term plan now form part of part of phases 3 and 4 of the recovery planning process, and we will touch on that in the item in a moment. So I think that's been you can call it either completed or superseded perhaps by recovery planning.
So let's complete or super. Is there? I don't know if there's a colour for superseded, but anyway, we're doing that. And then there's just the one at the bottom, Luton. This is a board-to-board, schedule a board-to-board meeting with the Luton and Dunstable. That feels like that's kind of a bit superseded, is that? Or here we are, that's been put on hold. Now, do you want to keep that on there? Or is that basically something that, you know, we're kind of starting off afresh, aren't we, in some respects?
Yeah, we'll revisit that once we're able to have face-to-face meetings again.
Yeah, okay. Right, next page is looking like a little bit more promising. The one at the top, that's work in progress. That's for November. Completed the third one. What's this one? The quality and performance report. The outcome of getting it right, the GERFT report. Final report represented to a future board.
Nicola, I think that one needs to tie in with the outcome of how we address in recovery, i.e. what we are doing to ensure that the stroke services are appropriate. And I think we need to bring that back in light of that.
Bring that in the recovery process. Okay. Right, next one. Patient experience for ESIST. That's an old one from Milton Keynes CCG. There was something about a patient experience report. Anybody know if that's going to happen?
It's Richard Alsop here. I think that's probably more in the service areas, the commission service area than Jane, because I know that was part of the evaluation that they were doing around ICSTs that has probably been put on the back burner. So we could probably take that away and get an update for next time around where
I think if we could just resolve it in some way, otherwise we're going to look at this wretched thing every time, aren't we? And the reality is life's moved on and things have changed and life's a bit different, isn't it, unfortunately? Yeah. So okay, so we'll take that away. And the one just below it, common themes. Oh, live life social prescribing. That's another similar one, isn't it? I don't know whether Maxine, you're there, aren't you? What if you want to say anything about that one?
I am here, yes. We've had a couple of conversations about this action, and I don't know why it keeps getting on here. We don't have any jurisdiction over the live life data, so I don't know how I'd ever supply it. But yeah, if we could close it off, and I questioned what it was about initially, and we've never really resolved that. So I think
there was something about getting some common themes and moving. I think the world has changed so much. Definitely. That actually that wouldn't necessarily be of much use to us. So I think we do close it down and not revisit it again, and then we'll just develop, obviously, the feedback. I mean, you've been providing feedback through all sorts of, the current situation, haven't you? So
yeah, definitely.
It's not lost. We're not losing the feedback. It's just a case of life is now different.
Yeah.
Okay. So if we're happy with that, we'll close it down and have done with it, because that's not really helpful. So how to report outcomes data and health check information to be discussed outside the meeting. That's an old one, isn't it? September 19. Can that be closed off? The bottom one.
So I mean, it's a really old one, and I know that lots of work was done on health checks reporting and trying to address some of the issues that reporting was highlighted. But of course, the programme then was suspended. So I sort of feel like it's kind of overtaken by events, and that a good chunk of work had been done previously anyway. So I would suggest it would be okay to close that one, unless anyone wants to disagree on that.
Yeah, no, I don't think that. Yeah, I think you're right. I think the trouble is we need to sort of, there's quite a lot of things here now that are kind of from the previous CCGs that were relevant at the time, but in actual fact, the world has moved on and we probably have not to be wasting time on keep revisiting them. So if we can remove them from the action log from here and take them away if necessary, I think that would be helpful. We may need a kind of a different colour from red, amber and green, don't we, to illustrate the kind of no longer relevant colour. Perhaps we can invent one. Okay, well that's that done. That's fine. I'm just going to have to get rid of this. I don't know whether I'm going to accidentally log myself out of the meeting. So if I do, apologies already. No, it's all right. We're okay. Thank you. Right. Okay, so we've managed that. So yeah, I'm sorry. This kind of agenda isn't really flowing for me at the moment because I've got a few things to say that I probably ought to have said at the beginning of the meeting. So let's just go back and do the sort of introductory thing. As I probably said, there's quite a lot of papers, a lot of work to do today, but I guess with a fair wind and team effort, we can get through it as before. I must admit, I was a little bit shocked at the size of the pack and how many papers there were, and had a bit of a kind of how on earth we're going to manage this type of panic. But actually, when you look at the papers, I think big thanks to all the people that have worked hard on aligning the papers, because obviously this is a committee in common. This is 3 CCGs at the moment, not a single CCG. So things have had to be brought together. There are papers now in this pack that actually apply to 3 CCGs, not a different paper for each individual one, which does make it a little bit easier. And I think it's just going to take a little bit of time for things to get well, a little bit less really, but I think the actual reality of the situation is that we are going to be a larger CCG. And I think what we have said to our members and to a lot of people with the CCG merger is that actually we don't want to lose the local approach, as well as keeping the big strategic approach, but not losing the local one. So inevitably, I do think that's going to mean a little bit of extra detail, which might be relevant even at the governing body level. So we'll have to just bear with that. And as we go through, we need to sort of think about how we can find better and easier ways of looking at all this information to make it useful and relevant to us. So we'll see how we go as we go along. So just apologies, there's so much, but bear with it. And if we keep going, I think we'll hopefully be able to see it through. The other thing just to bear in mind is that all the papers will have gone through various subcommittees, and there's a good number of us now on the subcommittees that will have seen these papers. Each paper will be presented by the person leading on that particular area, and we've also got the opportunity to ask any of the chairs of the subcommittees if they want to highlight any particular issues or draw anything to the governing body's attention during the meeting, to make sure we haven't got to sort of dig right into the weeds and get all the detail for every single item. Otherwise we'll be there till midnight, whilst at the same time making sure we get assurance that things are being handled appropriately and correctly. Having said that, I don't want to switch off all discussion and conversation about this, so please feel free, if there are areas of concern that you would like to raise, then please do so. We need to obviously be very focused as before on the subject matter here on the agenda. So the other thing just to say, obviously, if you want to ask questions or make a point, then there is the hand. You can put up your hand. As we've discovered, it's on the bottom right-hand corner of the attendees list. Now, the attendees list is quite long, so it's very easy to miss people's hand being up. So you might have to shout and draw my attention to it if that's the case. But do also feel free to post in the chat box, as Michael has done, because that's sometimes really helpful, and sometimes points then can be answered in the chat box itself. We are quite experienced at this now, so we should be getting good at it. But obviously, we're on the webinar thing this time rather than Microsoft Teams, so it's slightly different, isn't it? We just kind of got to get used to it again. Obviously, this is our first virtual meeting held in public. And we've, as at the beginning of the meeting, we did mention, obviously, to bear that in mind, that we're holding it in public. We are recording the meeting for posterity. So I know that all of you behave very well anyway, so I don't need to ask you to do that. But what I was going to ask you to do is when you're talking about things and explaining things, it might be really helpful to use plain English and try and avoid using acronyms that might not be understandable by everyone. So if a member of the public does want to follow the meeting, they are able to without getting confused by our language and terminology, which we all get used to and forget. Doctors are the worst, of course, at doing that. And I think it will help, you know, when people do pick this up on whatever it is, YouTube or whatever, they can actually see that and really understand what we're talking about. So that was just the suggestion I was going to make about that. Where are we? Yeah, and finally, just wanted to say that normally we would try and do a section with a patient story, just to sort of keep us grounded and remind us why we're doing the work that we're doing. And if we haven't got that today, so I just thought I would stick in a little reminder about the purpose of all this. This is all about patient care and doing our best for the populations of Bedford, Luton and Milton Keynes. And perhaps it's just a point to say, if we use the BLMK acronym, that's now been explained, so we can use that freely, hopefully, and people will understand what it means. So a big job at the moment to get the NHS back on track following the COVID surge, and obviously in fact, this is probably one of the most difficult times, isn't it, trying to get everything back working as it was before. Well, not back to normal, but in the new COVID environment. So that was just the first few things I wanted to say right at the beginning. And so I'm going to move swiftly on, actually. And the next item is Patricia's report, the Accountable Officer's report. So I'm going to let her have her speech. Thanks, Patricia.
Thank you, Chair. So you'll see contained in the papers an update from myself, which I'm not going to go through in detail, but I'm very happy to accept questions from the governing body members. I think the most important message to get across is an enormous amount of thanks. The last sort of 16 weeks have been unprecedented in terms of the pressures that all partners have faced, and indeed our frontline GPs. And I think it needs to be recognised here, the enormous amount of work that people have done and how well that Bedfordshire, Luton and Milton Keynes have coped with that surge. But not only sort of thanking our frontline staff and our CCG staff and our partners and local authorities, but also our wider community of people across Milton Keynes, Bedfordshire and Luton, who have embraced us and provided a lot of love and support over these last few weeks, and that's kept us all buoyant and focused on what's important. As Nicola has said, now we're moving into what we term in the NHS as a recovery phase, i.e. trying to get services up and fully running for people. It is really important that we get the message across to members of the public that we in return are here for them if they need our services in terms of care and treatment, and that is really, really important. So a huge thanks to everybody over these last few weeks. There have been a number of deep dive reviews where we've looked back at the last 16 weeks that it will be important for governing bodies to see, so that we can share that learning in anticipation of any kind of potential second wave, which we hope to avoid. I think my only final point here, in terms of the fact that we're on webcast with members of the public, and given our public health colleagues are here as well, is to remind people the importance of vaccination. And whilst it doesn't feel like outside that we're coming up to winter, obviously the flu vaccination and encouraging people to have their flu vaccine as we move towards the autumn will be really, really important as well. So getting that public health message across. So in terms of the detail of the report, I'm happy to accept any questions from the governing body members, but I think it was really important for our first webcast, governing body and public, to recognise the efforts of all of our staff across the CCG, both frontline and back office staff who kept the show on the road and made sure that we're as efficient as possible, and our wider partners in health service and indeed local authorities, but also our communities as well, who've done a phenomenal job in just managing this awful virus. So I'll leave it there. Oh, you're right. There you Still on mute. It's a really sensitive button.
All right. Can you hear me? Sorry, can you hear me?
Just, I don't know who that is.
Oh, sorry. It's Ashok Khandelwal from Bedford Borough Health Watch.
Hello, Ashok.
Hi. I just wanted to know a little bit more in terms of the exercise we had with the deep dive. Any further information on that? Because, of course, Bedford is very concerned about what's going on.
Yeah. So, so within, just to sort of update members of the public, and it's great that Vicky's here because Vicky's got some of the detail around this as well. But we were seeing slightly higher through May and June, slightly higher transmission rates, infection rates of COVID-19 within the population of Bedford Borough in particular. That triggered something called a deep dive review, which was done across partners, but also with Public Health England, so independent assessment of the data and the information. I think what's clear from that, and the interim findings were published a couple of weeks ago. The full deep dive report of that is due to be published in the next 10 days or so. But it's good news in the sense that whilst we were showing as being one of the top 10 areas 4 or 5 weeks ago in terms of transmission, we are now well and truly out of that top 10 zone, down to understanding the data on what was been going on, but also the huge amount of effort across the local authority and health partners and our local GPs actually in terms of putting a very clear message out to the general public around staying alert and following the guidance in terms of hand washing and so on, social distancing. And a number of our GPs actually did a number of different social media messages in various different languages and reached out to various parts of the community. And indeed, Health Watch, thank you so much, Ashok, also helped in that endeavour in terms of reaching out to the community. And putting that positive message out there, and that has had a huge difference in terms of those transmissions coming down. So we need to keep with that message as the economy and people get back to work and services start to get up and running again. But the full report and detail around that is due to be published.
Yeah, thank
you. Vicky, I don't know whether you want to add anything to that from a public health perspective.
From my point of view, fantastic. What do you call it, the language thing which came from Dr. Sharma, which I think was taken very, very well, very well done. But looking at the BAME population in Bedford, maybe, and I think maybe the question is for Jane, maybe that we need to do a much more sort of, language communication with various population. But the messages are going, and which is very, very good news.
Thank you, Ashok. We're enjoying working with you, and we're doing our level best to engage using the right language, working with local people and making sure that local voices are heard. So we're very happy to work with you offline, and I'll follow up after the meeting.
It might be useful for Vicky to come in because Vicky has been in, and the public health team have been integral to that deep dive review as well, just in case there are any final points around that, Vicky.
I don't have any further substantive comments to make. I think it's been a really, really great joint effort. We've had so many brains on it, including Public Health England, and we welcome their support as well. We've been able to look at the data in detail. We've been able to feel confident that there's no single overriding cause to which we can attribute the higher numbers of cases in Bedford, and we've also got good confidence that the numbers are coming right down thanks to the collective action of everybody, as you said, Patricia. And then it's really important that we all remain vigilant, particularly as we move into the autumn.
Agree.
Thank you.
Yeah, thanks for that. That's really good to highlight that, isn't it? I mean, that's one of the big big things that we've been looking at in the last few weeks. Right, brilliant. Any other questions for Patricia? Thanks for that, Ashok. That was good. Right, shall we move on? I'm on to the performance and quality report. Who wants to start? Is that
Nicola?
Maria?
Thank you. It's me. Yeah, I hope you can hear me okay.
Yeah, loud and clear, thank you.
Thank you. I'm going to start the report. I'm representing today on behalf of Anne-Marie, who's on leave this week, and Geraint is going to join me later on with some of the performance areas. So I'm going to take the report as read, if colleagues are okay with that, and just focus on the highlights of the report, with the caveat around the COVID impact. This is month 1, as we would call it, so April data that we're looking at, and the recognition around capacity, staffing across all of our service providers in issues around staff having to isolate, social distance in clinical spaces, etc. So all of that falls within some of the performance reporting we'll look at. The data itself, like I say, is around April specifically, unless it states otherwise. And one of the service areas is around psychological therapies, which is March data in the main that you'll see in the paper. The focus particularly, just to start with, our cancer services and impact around there in our highlights. So our 2-week wait referral from referral to treatment, and the 62-day from GP referral as well, we've seen deteriorating impact. So our 2-week has seen a 53% reduction in the timeliness of patients being seen within 2 weeks. We've also seen a specific reduction around the 2-week wait for breast treatment referrals, and a 33% reduction in our 62-day wait for cancer services. We have done some work locally around reminders for our patient population around the importance of still accessing GP services for any concerns around cancer treatment. And also we did some work with our communication teams around the GP leaflets for that, again, around cancer access. The other area to highlight is elective care and treatment around 18 weeks and the timeliness for people waiting for time of referral to treatment. And we've seen an increase in that waiting time of 42% for people waiting on an 18-week pathway. And one of our other measures is around people who wait beyond 52 weeks. I think last governing body, last period, we reported there was 11 people on that. There's now 65. And of course, we will know that that's been impacted by the national approach on pausing of some services to allow our acute service provision to deal with the emergency of COVID as it was. Diagnostics as well, in line with that, is another significant area that we've seen a real challenge around access to diagnostics. And again, like I've said earlier, that's been impacted around clinical environments and having to work in a very, very different way. Urgent care, I think, actually, in one of the areas looks like one of the places that has responded quite positively. So certainly our ambulance provision, our 111 provision, and access to A&E, although it's different, has had a good response. And of course, we've seen an impact on admissions being less now during this period. I think other areas specifically have been around our infection prevention and control, and certainly across the CCG, specifically our lead nurses with that remit have worked closely with our public health colleagues around sharing public health guidance, around working with our care homes specifically and supporting them around training for appropriate use of PPE, training our care homes around infection control and prevention as well. And I think the numbers around public health data around number of cases and number of deaths is further detailed in the report. We also know that specific areas of service provision, such as adult mental health, had been a challenge because some of that face-to-face interaction has been suspended throughout this period of April and beyond. But for those people who absolutely needed face-to-face, there's been different alternatives made available for those patients. Children's mental health has seen an improved provision, around access to crisis lines, for example. So that's a 24-hour service that's now offered across the community as well. I think specifically then, if I could just share with colleagues around quality of service provision, the data that we look at for April and beyond with regards to things like serious incidents, when we talk about quality to patients' health or impact, we haven't seen a significant impact in numbers around that. But for those that have been reported, themes like treatment delay, which would be in line with what we're seeing around service provision, have been a common theme. Our safeguarding approach has been consistent and working with partners across BLMK about ensuring that safeguarding is and continues to be a priority there. We do know that because of the impact of school closures, etc., and social isolation, that we may very well see more challenged cases around safeguarding across the patch, and we are responding to that. And again, we talked earlier about deep dives as part of the process within our clinical review. We will be looking at deep dive across different areas of provision. So we have looked at children across the patch on deep dive of cancer services so that we can address some of the issues that we're currently reporting here. But in that space of we have got reduced capacity, we're having to look at a transformational approach and to work to reduce waits, but also prioritise those patients who are really in need across our patch. So I'm going to pause there and welcome Garant if he's got something in addition to add to the paper.
Thank you, Maria. I think the key thing I would like to build on Maria's comments is in relation to page 3 of the report around the increase in our waiting lists and what that means for us and how we need to ensure that the increase in waiting lists, one, is being reviewed, as Maria's rightly said, patient safety and patient harm, but also how we're going to work with the item that is being led by Mike later on the agenda about how recovery is going to enable us to address some of the issues that Maria's talked about. And that is definitely linked to how we transform healthcare to enable us to provide services safely and appropriately in the new environment. I think we need to think how we tie the information together across those areas. So I think that's what I'd like to just add to Maria's comments and then take questions from the governing body.
Right. Does anybody have any questions?
Nicola, can I fire a question, Ashok, again?
Yeah, go ahead.
Great. I mean, there is a great improvement going on and we are into the recovery phase. Are there any plans to develop the accelerated clinics in order to catch up with the number of people who are already on the waiting list over a period of time? And it's a very hypothetical question, but very important for public to know.
Right, okay, thank you, Ashok. Would have any comments on the accelerated clinics? I know that the hospital are doing a lot of telephone consultations and things to try and get on top of the work, that's for sure. But any other special initiatives going on?
It's Richard. I would say yes, there are a huge amount of clinics and appointments being taken non-face-to-face, virtually over the telephone, and we're just introducing something called Consultant Connect in Bedfordshire. It's been around in Luton and Milton Keynes for some time, but it gives GPs the opportunity to speak with a consultant colleague and major patients can do need for referral sometimes. So we're looking at all different sorts of ways of managing that demand, as well as you say, as we bring services back, tackling the waiting list and the people that are on there. But outpatient care is kind of transforming quite quickly, I think, at the moment.
Okay, thank you. Kathy, I might have cut you off in your prime. Did you want to add anything?
Can you hear me okay? Yes?
Yeah, I can do, thank you, yeah.
Right. I just wanted to ask a question. Maria discussed the number of serious incidents which are being reported, which I can see that there is some variability across the patch, as we had 10 in Milton Keynes. And I just wondered if that was a blip because it seemed quite high. And also moving forward, as we move into the kind of the consequences of COVID and the fact that we can see that we've had lots of people that probably haven't attended hospital or to their GP, how are we going to pick up some of the possible harm that's coming out of this, and if reporting serious incidents will be continued in the same way, or is there any variability in that moving forward?
Oh, good question. Maria, do you have any?
So to answer Kathy's first question, I think the Milton Keynes, the 10 numbers are a blip. That's not a consistent report for Milton Keynes. But again, the themes around those are similar to Luton and Bedfordshire. They are around treatment delays, and then they are also around our mental health contingency, which we continue to have reported as, so where we see unexpected deaths, for example, we will see an SI coming through on that. And that's the same across Beds, Luton and Milton Keynes. I think for this period, the number is up at Milton Keynes, but that's not necessarily a commonality. What we have also seen, that said, in this period is because we are reporting an April period, we may have some catch up of serious incidents, as in providers reporting slightly later, but we don't believe that that's going to be significant across the patch. And I think you raise a really valid point around potential of treatment delays and potential of harm. So certainly we would see that through our cancer services work that is already in place. But I think the approach to look at that across all clinical pathways, that we work with our acute and community providers of where we see that and how we report that and understand it, will absolutely be the approach we will take moving forward.
Yeah. I think in a way it'd be very concerning if incidents weren't reported in a time of significant disruption. There's bound to be odd things that need reporting, and it's reassuring that they are still being reported, I suppose. Yeah. Any further questions?
Nicola, it's David Kempson from Luton.
Hi, David.
Hi. I just note in terms of the safeguarding that Luton has 2 children's safeguarding reviews due, and both are saying it's awaiting author. I just wondered, is that a temporary blip, or do we have an issue that we don't have the people to do the reviews in order for us to learn the lessons?
So I can respond to that, but partly to say I don't have that detail available to me right now, David, so apologies for that. We can certainly come back to you on that. I think it's unlikely it's about availability of people, because we don't normally struggle across the patch, but I haven't got the detail with me. I'd have to come back to you on that.
Okay, perhaps we can chase that up. Thanks, David. Any other questions?
I have a question, Nicola. It's Chirag.
Yeah, hi, Chirag.
Hi. So I think I've possibly actually got 2 questions. The first one is about the COVID-19 dashboard, which I believe is slide 9 of that presentation. And I guess what I wasn't quite capturing from here is the full impact that we've seen related to COVID-19. I guess to expand on that a little bit, particularly when we're looking at care home deaths, we know that in the early stages of the pandemic, because access to testing was essentially restricted to mainly in hospital, there were people dying in care homes where it may well have been and possibly quite likely to have been related to COVID-19, but not captured in that way in the statistics and the death certification. So a useful thing to do would potentially be to look at deaths in the same period over previous years. I suppose we're looking at talking about all-cause deaths here over previous years, and seeing what the difference is to get a better understanding of the impact of COVID-19 in environments where there wasn't such access to testing. So I think that would be a useful addition to this if we can do that, because I wasn't getting, certainly, it was well publicised that there was a particular care home in Luton where there were, I believe, 15 deaths over a period of a short number of days. I believe that's the right number. And of course, if you look at the care home deaths number in this table, it says 12 for Luton. So I think we're missing something in this data right now, and it would be helpful if we could capture that. So firstly, any views on that? And then I have a second question.
Nicola, it's Geraint. I'm more than happy to follow up with the information colleagues to try to get the information that Chirag's identifying. And I'm sure we can also work with our colleagues in public health to take that forward as well. So I'll talk to Carol and Neve from a performance perspective for CCG, and we'll follow up with colleagues in local authority as well.
Yeah. Okay, you happy with that, Chirag?
Yeah, thanks, Geraint. And the second thing is, I think the impact of the pandemic has varied, geographically, regionally. Some areas have obviously been hit harder than others, and I wasn't able to tell how do we compare, the impact it's had. Obviously, it's had a huge impact, and we can see that in some of this data and the waiting times. But getting an idea of similarly, I don't know how you'd quite have comparisons, but it would be useful to have some comparisons to know that, well, given the impact it had, or the number of deaths, or the number of cases that we've experienced, how do we compare with how others are recovering? Does that make sense?
Yeah. Maybe we need to look at that when we come to could we hold that thought till we get to the recovery plan and see how we measure that? That's a good point, though, I think. Okay, so let's just make a note. Any other questions for the current bit on the quality and performance?
Maxine here from Healthwatch Milton Keynes. Just a quick question. I noticed on page 18, regarding the cancer 2-week wait, the Luton seemed to be a lot less affected in terms of impact than Bedfordshire, Milton Keynes and the STP. How are systems and hospitals working together to look at, I think it's similar to what Chirag was asking in terms of, why we have certain impacts in certain areas and others have performed particularly well, really, in comparison.
Nicholas, Gary, can I come in there on that question on cancer?
Of course.
In terms of cancer, Maxine, we have a cancer board that covers BLMK, and that is chaired by one of the associate medical directors from the New Bedford Hospital Trust. That's Dr. James Ramsey. And I'm more than happy to bring in a future report how the cancer board is reviewing performance across BLMK, across all sites, and also how we can learn, as you rightly identified, what's worked well in some areas and then transfer them to other areas. So I'm more than happy to work with Dr. Ramsey around that and bring that back to a future meeting of the committee.
That would be really helpful, thank you.
Thanks, Maxine, for the question.
Can I ask a related question, please?
Yeah.
Linus Honor here. It's just basically in terms of the variation in performance, and thinking about the situation we find ourselves from a harm reduction point of view. Is there something about trying to potentially move patients across hospitals to try and reduce overall harm? So instead of having 2 hospitals where one patients wait for 10 weeks and in the other patient waits for 4 weeks, should we have some sort of evening up across hospitals if patients are willing to move across hospitals? Thank you.
That's a good question. I think there's something about how the hospitals are working together in BLMK, or are they all working in splendid isolation?
Nicholas, Geraint, I think that question needs to be taken into the conversation about recovery and how recovery is working across BLMK, and how we then take forward the point that Linus has mentioned into our conversations with the system. So how is the system responding, as Linus has rightly said, to areas where we need support? So I think if we take that point into the recovery conversation, that then can become a debate, can become an action for the executive to work with the broader ICS and the broader colleagues around that issue.
Yeah, I mean, certainly it felt during the COVID peak that everybody was working very much together and trying to get through it as best they could. So it's just a question of how is that panning out now, isn't it? And what difference has it made? Okay, I think unless anybody has any burning questions, we probably need to move on. Thank you for those reports. That was good. Let's move on to the recovery plan. And that's Mike, isn't it? I think that's yours. And this is just to look at the development of the recovery plan what we're asked to do is receive assurance on the development of the effective COVID-19 recovery plans to NHS England's requirements. Do you want to just introduce that one, please, Mike?
Sure. Can you hear me?
Yeah, thank you. Yeah,
good.
We can.
Just checking. Thank you. Good. I'm not proposing to go through the whole report. I think there's a number of important dynamics to the recovery planning process, and you've just touched on some already in the conversation. In terms of the report that's in front of members, what you've got is the narrative of the submission that was made on the 18th of June to NHS England in respect of the latest phase of our recovery planning process. It was at a point in time and was designed to meet the requirements of NHS England at that point. So if I can draw people's attention just to the cover sheet for the thing, there's a number of half a dozen key points just to note on there. That is on page, it's on 54 of my slide pack. Hopefully everyone's got the same one, but it is the page below the table with my name on it and what the governing body's been asked to do. And it's heads up key issues with the governing body. So there's just a few points from there to bring to people's attentions. Firstly, the narrative and a huge amount of detail that was not included in the plan was designed to meet the requirements of NHSE, with a lot of tables, a lot of templates, a lot of spreadsheets were submitted alongside this. Happy to share or discuss with anyone who's interested in the greater detail. That was all set as part of the requirements for NHS England. The second point there, which is an important one, and Geraint's just alluded to it in terms of how we work going forward, is about the system working together and how we brought the providers and other elements of the system together through the health cell, and the health cell has acted as the conduit to coordinating our recovery plan. And that, as my second bullet point notes, was also really well supported by the CCG's PMO, and many thanks to them for the work that they've done and continue to do. The other, and this is an important point, the third bullet point, that the narrative summarises the capital and revenue bids. You'll see in there 126 million of capital and about 76 million of revenue were bid for in the recovery planning process. Now, it's important to say that was part of the process. All systems were asked to include capital and revenue consequences of the plans as they designed them at that stage. At this moment, we hadn't had confirmation, or at the time this paper was written, we hadn't had confirmation of those. We understand at this moment that there is not going to be significant amounts of capital for multiple schemes given to local systems, but that there will be capital given specifically for A&E departments in the coming months, with the intention that a number of schemes that can be put in place to support both winter and COVID recovery by December will be supported going forward. So there's a gap as we understand it. We've not had the formal communication between what was submitted in terms of capital and revenue and what will be available. I think that was to be anticipated, in all honesty. The fourth bullet point on that summary then is that at this stage, and I think people will see in the plan because it's fairly evident, that it was very health focused, and in particular it was acute focused, not least around beds and activity and waiting lists. That was perhaps inevitable because that was the focus of NHS England in terms of getting into phase 2 of recovery, and you've just touched on in the performance report exactly the reasons behind that, which is that how big have the waiting lists become, how are we going to reduce the waiting list, how are we going to get on top of 52-week waits and 18-week pathways, as Maria touched on. All of those has been a prominent feature of the recovery planning in the early phases. However, what we do know we need to do, and always acknowledged, was as we go towards the further iterations of the plan, that we need to build in or bring in the social care, primary care, and more out of hospital components of the plans. There's a huge amount of work going on. It's not that that's not happening. It's just that it was not an ask of the recovery planning submission so far to include it in our plans. So it's almost a deliberate omission at that point. But we want to include those and need to include those more visibly in subsequent plans. And then the fifth bullet point is just to note that the feedback, which is on slides 23 and 4, was very positive. It did note that it was a whole system plan, It was well worked through. It was thorough. The mental health elements of the plan were commended. They were a separate appendix, so you've not got the detail necessarily in front of you. And that we therefore met the NHSE requirements. So there's something about the messaging which is that we sort of met the exam question as it was asked at that point. Huge amount of work went into that, but equally we know we needed to do more and broaden out the plan. So just to sum up then, the next steps on the executive summary, the national timetable was expected to conclude in mid-August in terms of submission of final plans, but we now understand that's going to be September. We've not yet received national guidance, and I think partly that's because that's been wrapped up in discussions with the Treasury about capital and allocation. So they needed to conclude that before they could issue the final guidance. So we are expecting that in July. We did make a further submission on the 16th of July, so just a week or so ago. That was not a full submission. It didn't change the narrative. It was just a further information in respect of activity templates, waterfalls, how updates on some of the narrative in terms of where progress has been made and so forth. So that was done on the 16th. We received, again, more detailed feedback on Friday, late on Friday, and we're just assimilating that at the moment. And that will be taken through the health cell, which is chaired by Geraint, on Thursday with our partner organisations to agree how we then proceed and what the priorities are for the next stages. The integrated care system, the ICS, is we've been working with them throughout this process. And there's an ambition that they have an increasingly lead role just in terms of holding the ring on some of the recovery planning, and we're agreeing with them and through the health cell how that works and how that looks and how the different partner organisations all interact, and who's pressing buttons to submit things but who's coordinating it. The CCGs has still got that significant role in coordinating the submission and will continue to do so, but we are very much mindful that we are part of the ICS and we're working in partnership with the ICS. This is not a CCG recovery plan, and we're at pains to point that out at all times. So, and then as the final statement said, and you said at the beginning, Nicola, this is to give you some assurance that we've been meeting the requirements to date for recovery planning. There's a huge amount to do. And as we move into the next phase, looking towards September, if that's the date that we finalise our plans, the work over the next 6 weeks really needs to nail down how we're going to bridge this gap, and the gap being our capacity versus the demand that has been building up, as well as the ongoing demand for turning services back on in the absence of huge amounts of capital. And therefore, how do we pull in the transformational activities? How do we maximise the use of video and technology to undertake consultations and to reduce face-to-face contacts wherever possible or wherever feasible, and recognising that throughout this we have a no harm, avoiding harm theme of the recovery planning work. And now we'll need to get into some genuine prioritisation of how we manage waiting lists, how we manage referrals for waiting lists, and how we take people through the referral management systems. And all of that will now have an increasing focus as we move towards the finalisation of the plans. I'll pause there.
Cool. Right, any questions for Mike?
I know it's Kathy again.
Who's that?
It's Kathy.
Oh, hi, Kathy. Would you?
Hello. So this is quite a large paper and there's lots of information. And I suppose what stands out to me is some of the solutions and mitigations and workforce issues that are highlighted in the paper. So obviously capacity is a major challenge, and moving forward they've talked about putting in modular wards and actually increasing capacity in some of the acute trusts and maybe wider community sites. Some of the deadlines are for March next year, and some of them are saying go live from 12 weeks from approval, but I'm not sure what that means, because it's just when we're hearing there could be a second phase possibly and winter pressures, I don't know how reassuring that is. And I don't know if you could just give us an update, because you are talking about considerable increase in workforce to kind of to deal with this, to actually manage, you know, it's 860 whole-time equivalents. And I just wondered how that's being monitored and how assurance is being provided around that. Thank you.
Thanks, Kathy. I think the short answer around the workforce, really, the workforce complemented the additional capacity schemes around modular wards, additional capital and revenue. We now believe that's not going to be the case. So we're not going to be, in terms of our final planning for 850 additional staff. That will not equate with the level of capital and revenue that will be made available. So that was what we would like as a system, because that's what we were asked to do. What we need to do in the next 6 to 8 weeks then is what we will be given, and how do we convert that into people and other capacity, whether that be the beds that we've got or increasing use of some types of beds. But more and more it will need to look at alternatives to bedded capacity, and therefore the workforce consequences of that, which can't be 850. So that was a point in time that we made the submission, but you're absolutely right to hone in on that, because even if we had the money and the capital, one might beg the question as to where we would recruit or find 800 staff between now and winter, for the sake of argument, depending on how you define the winter period even. But the NHS England are asking systems to look at as many of the initiatives that are relevant to this to be pre-Christmas. So it's interesting conceivable that any system in the country could identify 800 staff necessarily additional and deploy them in the way that's being described. So some of that was phased over into the new financial year, because as we touched on this in the action log, which is that the phases of recovery going into 2021 are very much the medium to longer term ones that are aligned to the NHS plan. So there's still an element of medium longer term planning here, for which of course workforce is a critical element, and therefore we will need more staff. What we need to do in the next couple of months though is work out the phasing over the 6, 12, 18-month period of how we deliver the recovery plans and how they segue into a refresh of the long-term plan and what the workforce requirements of that are. Does that make sense?
Yes, yeah.
Just to add to that, in terms of, goes back to Linus's very important point around how we utilise capacity across the system, because there is variability around that. So rather than just building more, to get the capital, it's how do we utilise what we've got to the most effectively. So looking at the waiting list, looking at capacity, looking at workforce across the entire system, so that we're utilising that capacity. And we're also utilising through the extension via NHS England the private sector capacity as well, to make sure that we've got enough capacity to move people through the system. Also, the clinicians in all of the acute trusts and in the mental health trusts are reviewing their waiting lists and doing a clinical triage to make sure that we are pointing people in the right place to receive their treatment, and also looking at how new referrals coming into the system are being clinically triaged, again, to make sure that people are going to the right place to receive their treatment and care. And as Richard mentioned earlier on, transformation has been quite incredible around particularly outpatients and the way that people are triaging and seeing patients, so that we can move patients direct to test or direct to list, as opposed to going through a number of different steps beforehand. That reduces that waste time and creates capacity. So it's looking at our capacity as a whole system, as opposed to just individual organisations within it as well.
I was just on the back of that you just said, Patricia, are we looking at how patients are being pushed towards different parts of the system? What I've got in mind is a number of patients that the hospital are trying to take off their lists and delegate down to GP practices to monitor, that would normally be monitored in the hospital. And is there any way of looking at, or anybody had any thoughts about looking at the amount of workload that's being handed down into general practice, which will impact on our resources and increasing our resources to be able to deal with that?
So I think the short answer is yes, but it's about how we put the clinicians together. So rather than hospitals assuming, because as part of the planning process, if the acute trusts and mental health trusts are making an assumption that X amount of work can come through, it's making sure that we're making that link with the CCGs.
Yeah, I'm not sure
to be clear on the capacity there. Yeah.
Not sure it's being measured. It's sort of a bit ad hoc. This patient here, patient there, tend to be, you know, can you monitor this blood test every 6 months, keep an eye on this patient? These are sort of like cancer type things that, you know, the sorts of elderly people with slow growing cancers that just need to be referred back at some point.
But I think it's a good point in terms of making sure through the next few weeks, as part of that recovery plan, that we ask for providers of all descriptions to make explicit any assumptions. So that we can be clear.
Not explicit. It is just kind of a gradual, you know.
Exactly.
And it's only the odd patient at the moment, but it all adds up, doesn't it? When you're trying to deliver like the flu vaccine coming up and all that kind of thing, you can't be having extra work from the hospital as well, and then be worried about patients not being able to get appointments with their GP, can you? Something has to give somewhere.
So I agree with both of you. The health cell, which is acting as the conduit, which does have through Nikki Pillane, the sort of primary care director on it. So we've got the inroads into primary care through that, and indeed the primary care plans feed directly into the health cell, and that's where they come together. It is having that. And it's got all of the providers represented, so that's where we have the conversation. And as Patricia says, is to be clear that in our plans, if there are any changes to criteria, that is an upfront agreed plan, and not just something that's happened by creep or stealth. And because we've got that forum now, if there are, you know, if there are incidents or if there's a pattern, and not just, you know, it may be small numbers, but if there's a pattern or perceived to be a pattern, we can have that conversation through the health cell with the acute providers to say which specialties, is it particular areas, is it particular consultants, and we can all, you know, take actions either into primary care or into the hospitals just to bottom that out. But the principle of the recovery planning process is that it is system wide, and that the impacts of the whole point of system working is that the impacts on one part of a system of an organisation doing something are recognised up front, and that we either mitigate it or in some cases may not do it because it's a negative impact that the system doesn't want. And so that's the nature of the system working through the health cell that we've we've agreed to maintain the health cell as that focal point, so that it gets the providers in the room with us, and we can have those conversations and ensure the plans line up. There is a parallel cell called the Health and Social Care Cell, just to make sure that all of those come together as well. So we believe, certainly me and Geraint do, that we've got this structure and the fora in place to allow us to have those mature conversations around knock-on impacts and people doing things within the system.
Yeah, I might send you a bit of evidence of the creep, if you like, because it's creeping.
Please do.
Can I make a point? Because I think Kathy mentioned about the second peak, and I suppose by way of some assurance around that, the things that were mentioned in the report are sort of additive to those things that we've already done already. So in terms of some of the really good work that was done at the beginning of the pandemic around introducing new discharge arrangements, purchasing additional community facilities and beds, additional patient transport, all of those things that are about getting people home, and all of the good work that was done around care homes with the general practices matched, all of that remains. And what we've done is we've continued the contractual arrangements into the winter, so that we'll have some resilience if there is a second peak, and all of that's additive to what's mentioned in this plan. So I just thought that was worth mentioning in terms of the assurance that we've got some resilience programmed to the system for that second peak.
Thanks.
Thank you.
Hi, it's Mahmood. I have a question.
Hi, Mahmood. Go ahead.
Yes, I suppose given that this recovery plan is based around the system and the ICS, I had a question about how we've got assurance about the impact of, you know, in council budgets and their, you know, decrease in services, which then has both a social impact as well as a potential health impact. And I suppose the other part, following on from Kathy's point, is how we're combining those into our respective risk register, both from a patient safety and quality, but also a financial perspective, given these quite large amounts of medical debt that we're building up. So two separate points there.
If I just talk to the first one initially, then it's a very good point you make around the council budgets, and that's there's two strands to that, in fact, and Patricia can jump in a second as well, because she's been having some conversation with the chief execs. So the local plans that encompass social care and voluntary sector and the services that are more local authority cited are very much part of the recovery planning process. They sit within the health and social care cell. So that those plans, as and when or if they are impacted, we will be able to quantify and ensure that the plans are reflective of, affordability or where the councils are in their current constraints, so that the whole system reflects each other's financial constraints, because the local authorities aren't necessarily just the only organisations, or certainly won't be going forward, who have those financial constraints. We all will in time. But the short-term constraints, for example, Luton Borough Council, which as we know has set an emergency budget, that the impact of that is going to be felt both in inequalities, which is a core theme of the recovery planning, and we will be, as we finalise our plans to September, setting out what we believe the potential impacts of both COVID, but also the inequalities impacts of reduced financial circumstances for local authorities. So they will be a discussion item in the plans in the next 6 weeks to understand what that means and how we can mitigate them. And then secondly, there is a piece of work that Patricia was asked to support, and I'm going to support her in doing it, which is to try and quantify across BLMK the impact of the financial constraints on the local authorities, and try and evidence what that means, and try and use that to either to lobby or to influence NHS England or departments or the government in terms of the specific impact in our local system. But what we're trying to illustrate is for example, the knock-on impacts of Luton having a budget constraint will impact on Bedfordshire, because Luton and Bedfordshire share fire services, they share police services. There's a number of services that, the borders are porous in respect of some of the services, and therefore the impact of one council on another will be felt quite quickly. So we're trying to quantify that and then take a view as to how we then influence our political leaders to support us in that. But going back to the first point, which is that the impacts will be recognised in the recovery plans, and we will either mitigate them or they will be shown as risks, and that will be a factor of risk management in the recovery planning phase.
Thank you, Mike. Yeah.
Thank you. Chirag, do you want to come in?
Sorry, my hand was just up from previously. Apologies.
Well, the only reason I did ask you, partly because you asked a question earlier on, didn't you, about how do we measure recovery and how we compare with other areas in terms of our performance on recovery, and that maybe just thought I'd bring that back up again at this point. Is there anything else to add to that, or is it just something to be mindful of?
Well, what I can tell you from a recovery planning process, I'm not going to answer any specific direct impacts. What we have set out and what the PMO have designed and Geraint's team, the recovery planning, we call it a monitoring framework, and what it's setting out is a whole range of metrics that we're going to be able to measure the recovery plans against. Now, some of those are your more conventional process measures. Has the waiting list gone up, down? Is the number of 52 weekers gone up? But we're also going to pull in a number of the more health outcome type metrics, and indeed COVID specific metrics, into a rounded framework, so that the recovery plan, as it's finalised in the coming weeks, will have a monitoring framework alongside it, and will have a set of detailed metrics that we can measure as we go forward to determine how effective our recovery plans are. So that's very much in development now. We took a proposal to the health cell 2 weeks ago. There was a bit of sensitivity with our provider colleagues that it looked like a performance management. It could become a performance management tool, and but we're at pains to point out that it's not about another performance management process. This is about measuring the impact of the recovery plan. So a bit more work to refine that monitoring framework, but it's the agreement in principle, and it was something that CCG said we can support the system with, is an effective framework for monitoring recovery.
Thanks, lovely. Thank you, Mike. That's really helpful. Okay, thanks. We'll be revisiting this in future meetings, won't we, I dare say, but that's really helpful. Thank you.
Definitely.
Let's move on, shall we? We'll move on to the next item, which is the NHS response to COVID-19, and that's Geraint, I believe.
Yeah, thank you, Nicola. A bit like the other speakers, I won't go through the paper in detail, but I would like to start this paper with building on previous comment. I really think we do need to thank all the staff in the NHS, both in terms of the CCG and our providers, and all the staff in the care home settings and social care have supported the population we serve over the last 3 to 4 months in terms of the COVID incident. I think this paper has tried to articulate clearly what the CCG's key role was within that process. So what we've undertaken as a CCG is our responsibilities as a category responder delegated from NGSC to coordinate the local health response and to work with health partners to ensure that we are responded appropriately to the COVID-19 incident. I think the key areas we've addressed are ensuring that we have an appropriate command and control process via the Incident Control Centre, which was coordinated by the CCG, and I'd like to thank all the staff involved in that. I would also like to thank all the staff of the CCG who worked with the executive team to basically create the health cells and the various respective health cells supporting that across the system. That's articulated in the paper. I'd also like to thank our partners for their support in terms of ensuring that we had the right interrelationships across the Bedfordshire Luton LRF process and the Milton Keynes system as well. So we have worked very closely with our partners across the local authorities. I know Vicky's on the call, so I'd like to thank Vicky for her support in terms of coordinating the tactical cell within the birth system specifically. I think the key challenge we had as a system, and we do need to note this, is the challenge around PPE initially, and then what the CCG then did to coordinate and respond to that. I would like to commend both Jade and Ola for their support in taking that forward. And I think obviously it'd be good to get perspective from our GP colleagues on the call. But I think the way in which the CCG responded to the challenge on PPE was very commendable in terms of we addressed it, we dealt with it. The next issue I think we need to be mindful of is how we did support around the care homes agenda and how we worked with local authority colleagues to ensure that the infection control procedures are taken in to care homes. And then finally, I think the key issue we addressed is the warn and inform aspects. The Jane's team and the communication team have worked by the both resilience forums to ensure that we're taking forward our warn and inform responsibilities. And Jane's team have worked very hard to ensure messaging has been taken forward. I'd like to thank the GPs on the call who have been supporting Jane and taking that forward. So thank you all, and I'll take questions.
Okay, any questions?
I have a question, if that's okay. Can you hear me?
Yes, I can.
Yes, we can hear you.
So I think it's absolutely appropriate to thank everyone and also to celebrate some of the successes of what has been clearly a very, very challenging time. I don't think this would be the right forum for it, but I also think probably there should be a different kind of conversation in which we focus on what worked well and what we would have done differently next time round. And I haven't sort of seen that conversation happen in the meetings that I've been in, partly because we're very much focused in what we're doing and where, and I don't know what that forum should be, but particularly with an eye on learning ready for winter, I think it's really important it happens with an emphasis on learning and not scrutiny or criticism.
Yeah, I totally agree, Chris. And I think on that aspect is I would like to work with our system partners. So I would like to work with both resilience forums to do a lessons learned activity from across the system. We can also build on the hot debrief we undertook whilst we were in the COVID incident to look at some of the lessons that came out of that. And I think what we could do is we could convene a CCG specific piece of work around what does the CCG need to learn itself about its processes, but also work with our partners in the wider LRFs about what the systems need to learn. And I think what came out initially from that was ensuring that we were understanding how we communicate effectively across the organisations and what we were doing. Also, how we were addressing in a speedily process what was being identified as challenges in the process. And then also, I think the key learning for me is how are we ensuring that the issues around the care homes and the points around how we effectively work across the system around managing patient flow are addressed into winter. So that's I think, the piece of work we need to do, Chris, and I think we should take that forward in the way you're suggesting.
Okay, thank you, Chris, for that. That's super. Okay, I don't think there are any more questions. So thanks for that, Geraint, and we'll move on then to the next item, which is the finance report. And I think Stephen's here for Chris to present that.
I am. Thank you very much, Chair. So I'm presenting the month 2 financial performance report for the 3 CCGs. It's worth noting, or important to note, that a temporary financial regime has been put in place for the NHS for periods months 1 to 4, so that's from April to July. For CCGs, that means that a national model has been calculated by our regulators, and that looks at what we are expected to spend over this 4-month period, and allocations, CCG allocations, have been adjusted to reflect the national model. There is a process of retrospective allocation adjustments, which means that where there are any variances to the plan, allocations can be provided to organisations to support costs related to COVID or any other particular variances which are justifiable. It's worth noting that in month 2, no retrospective allocation has been made to the 3 CCGs, and therefore combined we report a 18.1 million deficit across the 3 CCGs. That breaks down into Bedfordshire as a 12.4 million deficit, Luton a 2.5 million deficit, and Milton Keynes a 3.2 million deficit. There are 3 principal reasons as to why the deficit arises. The first is there are issues with the methodology calculation that has been produced by our regulators. They are aware of it. It relates to a very specific issue, predominantly to do with Bedfordshire CCG and independent sector contracts, which are considered or were considered to be within scope of the national arrangements for the independent sector. But in fact, Bedfordshire CCG has a relationship, a very significant relationship, which sits outside of the national arrangements, and that has been removed from CCG's allocation incorrectly. The second issue is there are some other allocation issues where the CCG is incurring costs to deal with national transformation programs or national commitments that have been made, and at this point allocations have not been received and were not reflected in the regulatory model. The third issue is the direct COVID-related costs. So that totals 8.9 million year to date across the 3 CCGs, and there is more detail within the pack. In summary, we expect a retrospective allocation adjustment to be made by regulators. We are still waiting for it to be confirmed, which should ensure that the 3 CCGs balance their costs. Their allocation is balanced to their costs, which means we should be in a break-even position for this 4-month period, although we are still waiting for more confirmation. It's probably also worth noting that the arrangements beyond the end of July are still not yet confirmed. So we do not know what happens beyond, into August and beyond. We have some informal around that. We are waiting for more confirmation, and that should follow in the next week.
Thanks.
I'll pause there.
Yeah, pause. Anybody got any questions? It's all a bit strange at the moment, isn't it? Not what we're used to on the governing body meeting. It's all a bit different. Everybody happy with that and got a good understanding of why things look a bit deficient on the money front, but there's all a good explanation around it. Really. Okay, I think it's fairly quiet, so I'm guessing that's all okay. Thanks, Stephen. Lovely. Okay, let's move on. Moving on to item 4.1. This is a draft BLMK CCG constitution. I think this is your thing again, Geraint, isn't it? Your item.
It's my item, Nicola, but I was hoping that Michael would take us through the detail as he has the legal mind better than I do.
Yeah, oh yeah, absolutely.
Thank you, Geraint.
Thanks, Michael.
Thank you. The Constitution is being presented for approval by the governing bodies for it to go out to really approve as part of their role as the CCGs members. So I'm not going to go through the detail of the Constitution here. The action that we're asking of you to formally tick the box to say that it can go out to members for their vote. I just want to note it is still a working draft. We are going to listen to their feedback back to the governing bodies in September. So if anyone's got any questions about the Constitution or its development, I'm happy to answer them. Otherwise, give it the nod to go out for approval.
Yeah, I think it's been circulated quite a lot, hasn't it, within sort of members, and people have been making comments, and I think certainly the LMCs are having a look at it to see whether one or two areas they might want to comment on. So this certainly isn't the sort of final moment for it, is it really? It's a case of, you know, just trying to get everybody to have a look and make sure they're happy.
Exactly.
Okay, all is quiet. That must signal content then. Okay, and just to remind me, Michael, that it comes back to does it come back again to the next governing body meeting in September again?
Yeah, absolutely.
Or do we just wait for the vote? Yeah, that's just before the vote, isn't it? Oh no, that's after. Sorry, I'm getting confused.
The vote is to be commenced on the 17th of August.
Yeah. Okay. Thank you.
22nd of September.
And then the submission needs to go at the end of September, doesn't it? So that kind of fits in. So anyway, anybody can, you know, in the meantime, thinks of anything they're concerned about, then to contact you. Is that probably the best thing, isn't it? Okay, thanks then. Yeah, lovely. Okay. So the next item is establishment of an Equality, Diversity and Inclusion Committee. Is that you again, Geraint?
That is me, and Roshan's on as well, so it'd be helpful.
Excellent. Hopefully non-controversial.
Hopefully non-controversial. Hopefully colleagues an opportunity to read the cabinet paper from Emma and also the questions. I think it's really important that we've said it on this meeting that we are committed and we are committed as a governing body to ensure that we are addressing the equality diversity needs across our 1 million population in terms of the potentially emerging CCG. It's also important for the staff we employ that we're showing we're an employer of choice for people from a diverse background. And it's really important that we take it forward. So I think the creation of this subcommittee of the board is an important step. It shows the intent from the organisation to do it and do it correctly. I'd also like to say that the people who've come forward to be on the Equality Diversity group have actually volunteered themselves, and they are from a very diverse background across our organisation. It's fantastic. And I would like to offer an offer to the governing board members. If any of you want to become part of the group, please put yourself forward to me or Rosh, and I'm sure we'll accommodate you. Rosh, would you like to give any perspective from your perspective, please?
Yeah, absolutely, Geraint. I echo what you just said. We had a very good for the volunteers from the all 3 CCGs. So we had the inaugural meeting on this one as well. So very much kind of a people are really interested in working in this group, actually doing their work around that. And we will be also arranging subgroups under this group as well, certain areas actually, especially the health inequalities around the BAME as well. So there will be different subgroups underneath this group as well.
Okay, thanks, Roshan. I did wonder on the terms of reference whether it was something that a lay member should get involved in as well, or is that not necessary or whatever? It just struck me that there might be an omission there, that was all.
More than happy to do that, Nicola. I think what we've tried to do with this forum is genuinely get people to come forward because they are committed and interested in doing it. I'm not there for a role or a remit. So again, as I just said to the wider governing body, if any of the governing body members wish to put themselves forward, just nominate yourselves and we'll accommodate you. More than happy to do that. But
I just thought it might give it a sort of balanced external perspective. That was all, rather than kind of inward looking. But I mean, if people are interested, then please put your hand up and join. Yeah.
Absolutely, Nicola. Yeah, thank you.
Yeah, thanks. Thank you. And everybody that's been working on that is, and a number of the GPs have taken an interest in that, I know. So that's really helpful. Thank you. That's approved. And it's to approve because it's a subcommittee of the board, it's to approve to have the chair for all 3 CCGs, isn't it? So the board needs to approve that.
yes, that's Nicola. That's the point we want. Yeah.
So
Nicola, sorry.
Yes.
Sorry, can you reconfirm how do we join it? The equality.
You just put your hand up and ask and speak to Geraint.
Yeah,
okay.
I think the colleague who's just asked that, Nicola, is from the Health Watch.
Right, okay.
And so we've got to be mindful that that's not formally an employee or a member of our organisation. So I'm more than happy to talk to Health Watchers about how we work with them around equality diversity. But actually the membership is from our CCGs family, if that makes sense. So more than happy to work with Health Watch around equality diversity, but you can't become a member of this group, I'm afraid.
Yeah. Okay. So Ashok's going to be work with you as and actually, that's absolutely right, isn't it? It's the whole world just isn't within the CCG, but we're happy to work with partners on that. Okay. Thanks, Ashok. That's helpful well, there's such a lot of interest, isn't there? Which is really, really positive. Excellent. Right. We're on to we're getting there now. Corporate risk registers. Front sheet, printed register. Sorry, I had a sheet of paper on this somewhere and I'm just trying to find it. Here we are. Right, I've got the risk register. Geraint or Michael, anything you want to say about this? Or is it just for us to have a look at? Any particular areas to highlight?
I think it might be helpful, Nicola, at this stage, if any of the chairs of any of the subcommittees wish to make any comments, that might be helpful. Or if not, we just take them as read.
Yeah, I'm just trying to enlarge it so I can see the thing now. So that's just the technical skills are getting there. Right. There were some risks, weren't there, on the action log, and they need to be added, don't they? Is that and we need to kind of refresh this for next time. And then it's a lengthy thing, isn't it? A lengthy document, but obviously there may be some things that need. This is very lengthy, isn't it? Is this that all 3 CCGs sort of put together?
Yes, it is, Nick. I think what I'd like to make a recommendation to the governing body is Michael and myself are working with the respective executive leads and chairs of respective subcommittees around the risk registers and the risk logs. We're also trying to do a similar piece of work around the board assurance framework. It's a work in progress. So if we agree that we are taking that work forward, and at the September meeting we have a revised what are called corporate risk register and a revised board assurance framework, which is taking into account all those actions, and then we can be more clear about where we are. Are you happy with that, Nicola, as the chair?
Yeah, no, I think so. It just looks as though there is some specific local issues, isn't there, that actually we can't be handling here, even though obviously we want to be aware of what happens in local places. It's probably not quite where it needs to get to, is it, at the moment? So it's work in progress, isn't it? But yeah, I agree with you. Take it away and then sort it out, because we're certainly not going to do it this afternoon. Okay.
Thank you, Nicola. Thank you, Chair.
I've got governing body assurance frameworks is the next item. Is that a separate item?
I think the comment I just made, Nicola, is relevant for the governing framework as well.
That's what I thought. So it seems odd to probably need to merge the two next time, don't we? Okay, that's all right. Okay, so we're doing all right. Look, it's just committee minutes, really, just are listed and included in the pack for you all to look at. We're just going to note them unless anybody would like to raise any particular issues. And all is quiet, which is good news. And anything else that needs to be any other business for this? I mean, we've got another meeting a bit later on Microsoft Teams, haven't we, to talk about a few other bits and bobs. But otherwise, I think that's the end of the meeting, unless anybody has anything else that has occurred to them. Otherwise, in a very timely manner, well, not too bad actually, we've got there. What I would suggest is everybody just has 5 minutes to have a little stretch and walk about, and then we'll go straight on to Microsoft Teams in about 5 minutes for our next meeting. And thank you everybody for joining.
Thank you.
I'm assuming this next meeting is the non-public meeting.
Yeah, that's right, Ashok.
Okay,
Yeah, thank you
thank
for joining and some very helpful contribution. Thank you very much. We'll see you next time.
Thank you.
Bye.
Bye. Bye-bye, everyone. Bye, Maxine.
Trying to leave. It's not letting me. It's probably crashed my computer now. There we are.
Stuck here forever.
Found a way. Thanks, bye.